Hi everyone, I am Vincenzo Berghella, and again, welcome to live AJOG MFM stream. Happy May 2024, and again, good morning, good afternoon, good night for wherever you are around the world. Thanks for so many of you for following. Today we're going to talk about cervical length screening, and I'm going to ask the panelists today to introduce themselves. Gabriele, you're first on my screen. You're muted.
Thank you. I am Gabriele Saccone. I am assistant professor at the University of Naples Federico II. And thank you for this opportunity to be here at this live social event.
Elena, good morning.
Hi everyone, and thanks for joining us. I'm an Italian resident in Ops and Gynae. I'm doing my residency program in Rome, Sapienza University of Rome, but I'm currently joining you from the UK, where I'm doing my one-year fellowship in Oxford, and I hope you'll enjoy this vineyard.
Thank you. Doran?
Hi, my name is Doran Kabiri, and I'm an OBGYN at Hadassah in Kerem, Jerusalem, Israel. I'm the head of high-risk pregnancy clinics at Hadassah, and I'm very happy to join this meeting.
Thank you, Doran. Ron?
Good day, everyone. My name is Ron Maimon, and I'm the chairman of the Israeli Society of Obstetric Gynecology and the chairman of the department in Shamir Hospital. And I'm very delighted and happy to be with you at this stage.
This is great. So we have a wonderful program. You can see here the 5 talks. Hopefully we'll go through them quickly and then we'll have discussion. I remind you that through Facebook and YouTube and X, Twitter, etc., you can ask us questions. So without further ado, I will pass it on to Gabriele for his first talk. This was a long-awaited trial that was actually presented at SMFM and recently published in the special edition of cervical length screening in the Pink Journal. Gabriele, take it away.
Thank you. Good morning to everyone, and I thank Elsevier and the whole editorial board of the Pink Journal, and especially the editor-in-chief, Dr. Berghella, for the opportunity to present on behalf of my co-investigator the result of this trial, the preterm birth screening study. So, both AJOG and SMFM both recommend ultrasound cervical length for women at risk of preterm birth, for women with a prior preterm birth, with the cervical cell class offered those with the short cervix. But both of them not recommend universal screening for low pregnancy, so women without prior preterm birth. Other society, for example, the World Association for Women, the AJOG, recommend a policy of universal screening with the cervical length at the second trimester of gestation. Several observational cohort studies aimed to examine whether or not the introduction of a universal screening was associated with a reduction in preterm birth, with some of them that show benefits in terms of reduction of preterm delivery, but the other, for example, the trial, the study of aspirin published on JAMA showed the low accuracy of such screening. Thus, we aim to test the hypothesis that the universal cervical length screening would reduce the preterm birth rate in singleton gestation without prior spontaneous preterm birth. I just suggest to unmute, so it was a multi-center, non-blinded, randomized trial of screening conducted in 2 centers in Italy from July 2018 to December 2022. Inclusion criteria were singleton gestation, no prior preterm birth, and gestational age at randomization between 18 to 23 weeks of gestation. Inclusion criteria were multiple gestation, prior spontaneous preterm birth, any symptoms of preterm labor, or cerclage or pessary in situ at the time of randomization. Eligible participants were randomized into 1-to-1 ratio, either to the intervention group or control group. Intervention group was a single scan of ultrasound at the time of anatomy scan. And we perform a sample size calculation based on the assumption of a 50% reduction rate of preterm birth from a baseline risk of 6.7%, with the alpha of 0.05 and the power of 80%. Based on this calculation, we calculate with an online software a sample size of 1,334 participants. The intervention group was based with one single measurement at the time of anatomy scan performed by certified operators. In case of a cervix equal or longer than 30 millimeters, we just offer standard of care. In case of cervical length between 29 to 25 millimeters, we offer another scan in 1 week. And in case of short cervix, defined as cervical length shorter than 25 millimeters, we offer vaginal progesterone 200 milligrams per day, along with Arabine pessary. In case of very short cervix, defined as 5 millimeters or shorter, we offer specular exam, and in case of cervical dilation or visible membranes, we offer emergency cerclage, along with vaginal progesterone. The primary outcome of the trial was preterm birth at less than 37 weeks, and secondary outcome were a different cutoff for preterm birth, 34, 32, 30, 28 or 24 weeks of gestation, and the neonatal outcomes, including preterm birth weight, admission to NICU, neonatal death, and the composite of adverse perinatal outcome. Overall, 1,334 women underwent randomization and were assigned to either cervical length group or to the control group. And we have a lost follow-up of 36 women in the intervention group, and 41 women were lost follow-up in the control group. The baseline maternal demographics were similar between the two groups. And this is the results of the cervical length measurement in the intervention group. So we had a short cervix rate of 1.9% in women with 25 millimeter or shorter cervical length, and just one woman had very short cervix, so cervical length of 5 or shorter. 26 women had the cervical length between 25 to 29, and then the follow-up cervix scan in 1 week. And of them, we had 2 women with the short cervix and 1 woman with very short cervix at follow-up scan. So overall, we had 50 women with the short cervix. All of them received vaginal progesterone. 11 received Arabine pessary. 2 of them refused to receive Arabine pessary, and 2 of them, because of very short cervix and cervical dilation more than 1.5 centimeters, received also cervical cerclage along with vaginal progesterone. This is the results of our trial. So overall, none of the outcome were significant, but we found a non-significant decrease by 40% for the primary outcome. As you can see, preterm birth at less than 37 weeks with a relative risk of 0.86, and also a non-significant decrease of preterm preterm labor with a relative risk of 0.73. But these are not significant because, as you can see, the confidence interval across 1. These are the results of the perinatal outcomes. Even in this case, all perinatal outcomes are non-significant, but we have found a non-significant decrease by 27% for neonatal outcome, relative risk of 0.73. Regarding the adverse event, the cervical length scan was well tolerated with just 5% of pelvic discomfort and 1.6% of pelvic pain during the procedure. So the strength of this trial is that this may be the first RCT of screening in low-risk population. We have a strict protocol based on intervention for women with short cervix. Overall, there are several limitations of this trial. First of all, we have a higher rate of preterm birth compared to expected, and also a decrease for the primary outcome of 40%, so lower than expected, because our assumption was a 50% reduction rate of preterm birth. So basically, this trial was underpowered for the primary outcome. because based on this new calculation, so the new rate of preterm birth in the control group, and most of all, the right reduction rate of preterm birth, we need more than 8,000 women to found a significant decrease for the primary outcome. Another limitation is that we use the Arab impessary in the intervention group. This is not routinely offered in other countries, for example, in the US, mostly after the latest RCT, American RCT, which is negative. Of course, we found a trend for benefit in our trial. Maybe the lack of a significant benefit is associated with the underpowered, the small sample size, but also on the low rate of short cervix, and also on the very low rate of the very short cervix, less than 1%. Another point is that 1/3 of the included participant and multiparous, so with a prior term birth. In this case, the risk of preterm birth usually is lower compared to a nulliparous women. So in summary, we found that the introduction of universal screening of cervical length during the mid-trimester of gestation in singleton gestation with no prior preterm birth, and the treatment with the vaginal progesterone Arab impessary for women with short cervix did not result in lower incidence of preterm birth. However, given the non-significant benefit associated with such policy of screening, future larger RCT are needed. Thank you for the opportunity to present this result. Thank you.
Thank you, Gabriele. They're fascinating randomized trials. We're going to move right along. And this is a multi-continental meta-analysis that Elena is going to present from London. Elena, go ahead. Thank you.
So hi everyone again. I'm going to present you the results of this systematic review and meta-analysis we recently performed with Professor Berghella, Daniele Di Mascio from Sapienza University of Rome, and Kamran Essami from Boston University. So Gabriele has already given us a bit of a background, but still only ESO guidelines are recommending transvaginal ultrasound cervical length in a universal setting for asymptomatic individuals with no prior PTB. And still, this is a category of individuals that are labeled as a low-risk pregnant people, but in truth, they might have many other risk factors for PTB. And the role of this systematic review was basically, the aim of this systematic review was basically to assess the benefits in terms of risk reduction for spontaneous preterm birth in a universal transvaginal ultrasound assessment of the cervical length. So the inclusion criteria of our systematic review and meta-analysis were singleton pregnancies, receiving versus not receiving the transvaginal ultrasound assessment cervical length, and all the studies that assessed the transvaginal assessment of cervical length as a second-line screening method were excluded. So although it was performed later at transabdominally suspected short cervix. And the literature search yielded 1,030 studies, of which after full assessment, we included 8 studies in our systematic review. So the total population size was accounting for 447,864 individuals, of which roughly 1 in 2 were receiving versus not receiving universal transvaginal ultrasound cervical length. And by looking at the data, we see that the parity rate, so there was a 50% rate of primiparous, and the prior PTB rate was reported just in 4 studies that were not considering it as an exclusion criteria, and the overall rate was just a 5%. So these are briefly our results, and as you can see on the right, there is the overall population and the overall statistical analysis, while on the left there is our subgroup population. That is the main focus of our systematic review. So we wanted to assess really the benefit of universal transvaginal ultrasound cervical length in this category of individuals. So looking first at the overall population, we had a significant risk reduction of 16% in spontaneous preterm birth occurring before 32 weeks. And this risk reduction was slightly decreased with advancing gestational ages, but we had at least a trend in risk reduction of 8% for spontaneous preterm birth occurring before 37 weeks. By looking instead of the data in our subgroup analysis that was accounting for 92,000 individuals, we had a significant risk reduction instead of 12% for spontaneous preterm birth occurring before 37 weeks. And we had likewise an increasing risk reduction for earlier gestational ages. And we had a quasi-significant result for risk reduction of 18% for spontaneous preterm birth before 32 weeks. So we had very impressive results and very significant results for similar gestational ages between the two statistical analyses, the overall and the subgroup analysis. But we think that we might have achieved even more significant results if we had less limitations in our included studies. And we acknowledge these limitations, and here I've highlighted the most crucial ones. So basically, definition of a short cervix. Only 4 studies were defining a short cervix in line with the current guidelines, so with a threshold less equal than 25 millimeter. 3 studies were using 20 as a cutoff, and 1 study only as 15 millimeter. These were the definition at which the included studies were starting and were prescribing preventive strategy. But still, if we look at the data of individuals with detected short cervix that received progesterone, so our first-line preventive strategy, this was roughly 60%. So there was quite an undertreatment of this condition. And this is not entirely justified by the overall rate of individuals and also the asymptomatic individuals with no previous PTB that were receiving Cerclage, so 24% and 15% respectively. But despite these limitations, we think that once again, this systematic review and meta-analysis confirm transvaginal ultrasound cervical length as a successful screening method according to the WHO criteria. And we think that our results highly supports and highly recommend the AJOG guidelines. So we hope that in future well-designed RCTs with adequate sample size and with a strict adherence to preventive strategies might ever confirm our findings. And these are far-reaching conclusions from my point of view, but I really hope that well-randomized RCTs are coming.
Thank you, Elena. That was great. So well presented and really wonderful done. Wonderful study. Ron, you're sharing your screen and you're next talking about the cost effectiveness of cervical length. I'm going to unmute you. So you're live now. You can start.
Thank you very much. I will discuss about two things. One is the impact of introducing cervical length measurement for all pregnant women and the cost benefit of this procedure. And as we all know, premature delivery is a serious disease affecting about 1 to 8 deliveries every year, causing all the problems of prematurity and neonatal suffering. And back in 2012, we had a long discussion in our organization, and we have decided to implement and to recommend routine second trimester cervical measurement to all low-risk population in Israel. The guidelines that was introduced in 2012 was accordingly that each woman will have a 2-stage approach. First, we'll start with cervical measurement by transabdominal approach, and if this will be obscured by any kind of abnormalities or the cervical length was suspected to be smaller than 25 millimeters, additional measurements should be taken. The guidelines recommend that special time will advocate for this procedure. And after 20 years, we look at the registry of the Ministry of Health in Israel to analyze the outcome of two populations: the population that were screened after the introducing of our procedure and those who were not screened. So in a 20 years period of time, we come across about 3.5 million live-born infants. 50% of them were screened and 50% didn't underwent the guidelines which I explained. And what we saw is that from the introducing of our guidelines, there's slightly a drop of the premature deliveries. And if we look into more details, then the premature delivery rate was reduced in overall from 7 to 6, and it was significantly, and then it was reduced from in each gestational age group 33 to 36, 28 to 32, and lower than 28. We also show that according to fetal weight estimation or newborn weight, it was reduced in infants smaller than 2,500 grams and even 1,500 grams. This procedure was efficient only in singleton, whereas in twins and multiple pregnancies, it didn't show any benefit. And what we'd like to emphasize that in most countries nowadays, second trimester is implemented. There is knowledge and equipment about scanning and screening of all fetal and maternal organ, and implementing this procedure is very easy and very useful. And then we analyzed the methodology to see if we can also provide a financial explanation to this kind of screening. And according to our model, in which we look at the population that were not screened and we were screened, we found that some parameters are very useful, including the ultrasound measurement, including the epidemiology, the probability of low birth weight, and the cost of treatment. So a universal screening and the increased quality of life in our model produce a saving of $8 million US every year, and reducing the cost for avoiding every case in $14,000 US. The major parameters affecting the saving of premature delivery were cervical measurement, progesterone, and the efficacy of preventing a premature delivery. This was the first national screening program that has been proposed whatsoever, and our take-home message is that introducing a routine second trimester two-stage screening, cervical screening, is efficient, is cost-effective, and deserve a national policy worldwide for this procedure. Of course, further studies are needed to validate our experience, and for those who are more interested about our studies, they can find more details in two recently published papers. And at this stage, I would like also to thank our collaborators and thank you for your attention.
Wow, that was great. That's so impressive. Your data is so impressive. I'm so happy. And again, this comes from the president of the society. So wonderfully presented. Well, we're going to stay in Israel. And Doran, you can take it away. I know you're sharing your screen, so I will try to find your screen.
Okay, you see my screen?
And share it. Yep, here we go. Thank you for being with us.
Okay. So hello everyone, and thank you for the opportunity to present our recent study regarding the validation of cervical length staging for preterm birth prediction. It was conducted with my esteemed colleague here in Jerusalem, Israel. For over 25 years now, following the pivotal study of IMS published in the New England Journal of Medicine, we have understood that a short cervical length is associated with an increased risk for spontaneous preterm birth. Additionally, this study highlighted that the shorter the cervical length is, the higher the risk for preterm birth. Despite its clinical importance, the definition of short cervix varies significantly across studies. As you can see here, less than 15 millimeters in some studies, less than 25 in others, or even a range between 10 to 20 millimeters, as you can see in the pregnant trial. This inconsistency highlights the need for a more nuanced understanding and standardized categorization for cervical changes. It is clear that a short cervix is not a single pathology, and the risk for preterm birth for a woman with cervical length of 24 millimeters and a closed cervix is dramatically different compared to a woman with cervical length of 2 millimeters and prolapsed membrane. Following this concept, Roman and colleagues in 2023 published in the AJOG MFM a proposed novel staging system to address exactly this variation. This system categorizes cervical changes into 5 stages, ranging from minimal to severe. This approach allows a more precise risk stratification and tailored clinical intervention based on the severity of clinical changes. As mentioned, this system categorized cervical changes into 5 stages, from minimal to critical, reflecting the severity of this condition. Here is the brief summary of the stages. Stage 1, minimal changes. This stage represents the least risk within the stage system. The cervix is relatively long with no physical sign of opening. Mild changes, stage 2. Here the cervix is shorter but still maintains its structure and integrity without any cervical dilatation. Stage 3, moderate changes. It indicates a higher risk as the cervix begins to dilate. While the membranes are not yet protruding the cervix, they can be palpable upon examination. Stage 4, the severe changes. In this stage, the membranes are visible within the cervical canal, and in stage 5, the most severe stage, the membranes are prolapsed into the vagina, indicating the highest risk for preterm birth. So this staging system is very elegant, but it's crucial to remember that for any proposed system needs to have a validation. To this end, we conducted our study, led by one of our talented physicians at Hadassah, Dr. Hadar Gavra, that validated this proposed staging system. We performed a multi-center retrospective cohort study across 3 centers encompassing a substantial patient population. This large-scale study provided us with a robust dataset, including more than 110 cervical length measurements taken from asymptomatic singleton pregnancies between 18 to 24 weeks of gestation. From this cohort, we identified 925 women with a cervical length of less than 25 millimeters, who were then categorized into stage 1 through 5 according to Roman's categorization system. Our primary outcome focused on the incidence of preterm birth before 37 weeks of gestation. This finding demonstrates a clear escalation in the risk as the stage advances. But this is not enough. To truly appreciate the significance of the 5 stages, we further investigate the incidence of very early preterm birth. These are the results of our secondary outcome focused on the incidence of preterm birth before 28, before 32, and before 34 weeks of gestation, with the complementary 37 and the term deliveries. This detailed information is crucial, especially during the counseling session with the expectant couple. Understanding the specific risks associated with each stage allows the healthcare provider to offer tailored advice and intervention. This graph helps to set a realistic expectation, prepare the potential preterm delivery, and discussing proactive management strategies to mitigate the risks. This comprehensive approach ensures that couples are well informed and can make decisions that are best suited for their circumstances. In conclusion, our validation study confirms that Roman staging criteria significantly enhance our ability to predict and manage the risk of preterm birth. The system facilitates more informed counseling, precise intervention, and tailored management plan for the pregnant women at risk. On the closing slide, you can see 2 figures, one illustrating the 5 stages of cervical changes, and the other demonstrating the corresponding risk for preterm birth. I share this illustration with my colleagues in our WhatsApp group every couple of months. It's very practical, easy to use, and help us to provide a standardized approach when evaluating patients with short cervix. I highly recommend you to do the same. Thank you for your attention.
Wow, that was great. You guys did amazing presentation. I just want to spend a minute here on a personal note. First of all, when we received the Pink Journal, Dr. Kabiri's study, we thought it was a joke because we came up with the Roman quote unquote staging, thinking that it was important. But you never know. You publish an article and you think nobody reads it sometimes. But again, thank you to the Pink Journal. Thank you to our Israeli colleague. You guys did a beautiful, beautiful job. I remember like 10 years ago when people were attacking universal cervical length screening in the US and called for randomized trials. We need to do randomized trials in the US and other places. The only one to do it are the people in Naples, led by Dr. Saccone. So thank you for doing that. I remember when Elena's collaborator, Dr. Simi, I think it's his name, proposed a meta-analysis, and I'm like, I don't know, so many meta-analysis. Well, what a wonderful paper, what a wonderful presentation, what I think, important data coming from all over the world, almost 500,000 people, screened. And again, Ron in Israel as well, cost effectiveness studies before were done, but never really as elegant, as large, as nation wide as yours. So I think yours is also important, and I thank you for sending it to the Pink Journal. I'm going to share quickly a few slides. One, for discussion. I think that now AJOG, SMFM, every AJOG. We'll discuss about Israel. I think that there are a lot of reasons to do transvaginal scanning instead of transabdominal. You can see it in the slide. And apart from the society, cost effectiveness, etc., in the United States, there are legal issues. I have seen a couple of cases of babies born preterm, and if the practitioner obstetrician would say that the screening was done transabdominally, you could actually lose that case. We published in that special issue in AJOG MFM something on technique as well that I wanted to share quickly with you. It's really important, obviously, to do this as you implement it in your place or your country correctly, so you can see the external os, the internal os, the entire endocervical canal. And sometimes you have contractions. There are now even randomized studies show that, especially after bladder voiding, if your patient, voids, urinates just because the ultrasound, then it's up to 40% that you can see these contractions, as you can see in the top, and then the same image in the bottom, highlighting the contraction. It's important you only measure the remaining cervical length, and we think that this is due to the fact that there are actually muscle fibers, as Joy Vink has taught us, at the level of the internal os that can contract, and you can see it on ultrasound. And so we came up in this, again, Pink Journal article in the special issue with a little bit of an algorithm. Hopefully you do the transvaginal ultrasound at the beginning of the scan and you don't see any lower urine segment contraction. But if you see it either at the beginning or towards the end, then in this lower right rectangle, you can see that you can wait, but if the contraction stays till the end, you should record the cervical length the way I showed you, only measuring, as in the bottom, the true cervical length. Sometimes actually they can mask a short cervix, especially in people with preterm birth. So sometimes we even have, if you have a preterm birth, we even have the patient come back in a week or so to make sure the contraction is gone. A couple of you has gone over this amazing trip, which I kind of lived, not all the way from the 70s, but certainly from the 90s on. Cervical length has been around for a while. Cervical length has been around from really now 50 some years. kind of a major Anderson paper in AJOG, then the IAMS papers, then the first randomized trials. Then, as Ron showed us, kind of cervical length screening began in 2011. We started in 2012 at Jefferson, and then finally now guidelines that recommend it, and people use this term universal full singleton with no prior preterm birth, which are like 90% of our patients, so many of our patients. And I'm just going to go over 15 reasons they keep on building why cervical length screening is so important. In fact, I tell patients when they come for the anatomy scan that perhaps the most life-saving thing we can do on that anatomy, morphologic scan at 20 weeks, it's the cervical length transvaginal ultrasound screening. Because preterm birth, kills so many babies, still kills, a baby every 30 seconds around the world. It's predicted of preterm birth. There is this recognizable, like Helena said, pre-symptomatic stage. Then we know the rate of natural history shortening. The rate is well accepted. That was shown also by Gabriele. 95% have no problems with the test. We have the facility all around the world. We now have Dr. Saccone's randomized trials, which is underpowered, but is wonderfully done and shows benefit. We have Elena's systematic review, which also shows benefit. We have run cost-effectiveness studies and other ones, but this one at the national level. And we didn't cover it, we'll cover it in the future, vaginal progesterone, in some cases cerclage as effective treatment with accepted guidelines when the cervix is short. This is done now in the US pretty routinely, not only in other countries. This is 2015, the majority of academic places were doing this. It is recommended in prior preterm birth in basically every society, and the effect of progesterone and cerclage are similar in our population, making the case that probably also for those with no prior preterm birth, the effectiveness of progesterone and perhaps cerclage is the same. And I'll show you some data that cervical length screening in asymptomatic women decreases preterm labor later on. As a few of us said, AJOG in 2022 recommended cervical length screening. They recommended transvaginal ultrasound, 25 millimeters as cutoff, no pessary, no reduction in activity. And again, one cervical length, usually around 20 weeks, vaginal progesterone for everybody with a cervix of 25 millimeters or less. And they actually talked about cerclage for those with a very short cervix. So kind of using this schematic. But as you can see, vaginal progesterone still has a lot of early preterm birth, less than 33 weeks. This is the Romero meta-analysis that we all use. And again, this has been around now for 7 years, for quite a while. As you can see at the bottom, 35% decrease in preterm birth with vaginal progesterone, singleton, no prior preterm birth with a short cervix. And in terms of cerclage, everybody quotes, including AJOG, SMFM. This meta-analysis we published now, again, it seems yesterday, but it's 7 years ago. I just want to show you that if you look at 37 weeks, 35 weeks, all this cutoff, cerclage is in red. Cerclage always looks better, really, after 32 weeks. The numbers are very small, before 20 weeks. But this was not powered to look at that. And if you look at short cervix, AJOG and now SMFM are using 10 millimeters as cutoff because in this meta-analysis we saw a 32% decrease with cerclage. But there was a trend for benefit for less than 15, less than 20, and even less than 25. So hopefully with more data, we'll have a better idea. But it seems like cerclage could help even with longer cervices. And we showed also that indomethacin and maybe one dose of antibiotics was beneficial in this meta-analysis. So today is the 20th. So 6 days ago, you probably saw it, SMFM, the Society for Maternal-Fetal Medicine, the premier society here in the US, came out with their recommendation for cervical length screening. The whole document by Dr. Joey Biju, a good friend, was in women with no prior spontaneous preterm birth. Like Eastwell recommends cervical length screening only by transvaginal ultrasound. Like Eastwell and all of us using 25 millimeters. So we all agree across the Atlantic and across the world. And in singleton with a short cervix, they actually say you can use vaginal progesterone. They recommend it less than 20, and you can consider 20 to 25. I'm a little disappointed here. The relative risk in Romero's meta-analysis was 0.55 for 21 to 25 millimeters. It was not significant because the numbers are small in this subgroup, but you can see that vaginal progesterone works all the way to 25 millimeters. And they also say, because of that meta-analysis I just showed you, to consider cerclage for less than 10 millimeters, and they say no cerclage for 20 to 25. They say no pessary, and in twins, they want to see more research. This is what we use as well, and we just finished our randomized trials with Dr. Bolig, which I show here in the top right, and that randomized studies randomized 90-some women to cerclage or no cerclage, and those results hopefully will be presented in Rome in September. So can't wait to show you those results. Please come to this next meeting. This is the data that I mentioned, that cervical length screening universal decreases preterm triage visits and admissions for preterm labor. I think you would find the same in your unit. And lastly, I want to close my part on the fact that I think in the future we'll see maybe cervical length extended more than 24 weeks. There is data that we published in the Pink Journal by other authors. In this special edition, Dr. Chung presented data that cervical length screening can be predicted before 16 weeks. There was also data that cervical length is predictive for placenta previa in terms of who is going to deliver emergently and who is going to bleed. And there's also data that cervical length can predict spontaneous labor when done at term. So with that, I'm going to end it, and we have almost 20 minutes for discussion. I think we presented a strong case for this, and again, this was actually not planned. You all sent spontaneously your data. I'll open it up to you if you want to ask any questions. Anyone? Otherwise, I can start. Ron, can I ask you, in Israel now, do you recommend cervical length screening by transvaginal ultrasound, or you still allow transabdominal?
I want to say a few things about it, and even go into the medical legal aspect. First of all, we look at no doubt that transvaginal is better than transabdominal. But if we look as transabdominal as a screening test, it has the limitation of any screening test. And if we are happy with the image that we get, and a woman who gets to a premature delivery, it's not us, it's the screening policy. It's not us, it's the test. And we don't have to take upon ourselves the guilt of doing a good scan and getting a bad outcome. And the litigation that we come across nowadays was that there is a linkage between anomaly scan and cervical length measurement. And there are cases of women who don't want to have anomaly scan at mid-gestation. So they were not referred to any kind of scan. And among them, there were women who delivered prematurely. Now, we specified that every woman should be offered a cervical length measurement at mid-gestation, irrespectively if she's going to have an anomaly scan or not. This is a separate issue, a separate organ, and deserve a separate consideration. And we implemented this paraphrase in our guidelines. So we believe in transabdominal, we believe in screening, and we believe that this kind of test should be offered irrespectively of the anomaly scan. And another thing which I want to raise is that we feel that cervical length measurement in twins was less effective. It did not improve the outcome. I think that in between is the therapy. I think that the test it might be good. The problem that we didn't see any benefit is because we didn't come across a useful treatment for twins and multiple pregnancies, and is not the test by itself.
Could I know Doron wants to say something, and I'll move to you, but Ron, do you use vaginal progesterone for twins with a short cervix in Israel or not? No.
We use all the methodology. In my department, we use also Arabin pessary. We use progesterone, but nevertheless, we didn't see as much as benefit as we see in singleton.
Yeah. Okay. Doron, did you want to say something? You unmuted yourself.
No, I completely agree. It's the same policy that we do also in my institute. There is some minor difference when we do the scan abdominally and we see the cervical length is above 30 millimeters. Then we might predict or say that maybe the vaginal is long enough, and not necessarily we do also the vaginal scan. But this is only when we see very well structured cervix, which is longer than 30 millimeters. In the major parts, usually we tend to do the cervical length screening vaginally, which gives us the most predicted outcomes, and we see the results. We see the connection, straightforward.
Elena, can I ask you to comment? How do you do it in London?
So here we follow NICE guidelines and RCOG guidelines, and we tend to do transvaginal cervical length in individuals with a previous PTB or in individuals with other risk factors. So, for example, it is obviously different for gestational ages at which we offer the transvaginal ultrasound assessment, because for patients with previous preterm birth, we start offering a transvaginal assessment from 16 weeks. Whereas, for example, in multiple pregnancies or individuals with a prior surgical intervention on the cervix, they offer the transvaginal assessment around 20 weeks, so around the anomaly scan. The fact is, for example, I think that I really want to comment with you is that when these patients are coming for their transvaginal assessment, it's usually another day scan compared to their anomaly scan. So they book these patients again for another transvaginal assessment, and they obviously they have two appointments for two different scans at 20 weeks. And I think that this might be, I think that one single scan might be very useful and should be probably considered. But this is something that is not really happening here. But here there is much more attention, for example, to the environment that is around the transvaginal assessment. So, for example, here there is a lot of attention to the chaperone and to the sonographer that is performing the transvaginal assessment. So there is much more attention to this kind of things that, for example, in my personal experience in Italy, is not that relevant. So I think that there are also cultural differences, and I think that another thing that is really important is to assess the acceptance rate of transvaginal assessment and to work a bit on it. So, for example, there are several studies that have mentioned roughly 80%, 85% at the highest of acceptance rate for transvaginal assessment. But if we look at the reasons why these women have refused to undergo a transvaginal assessment, they are kind of modifiable. So, for example, in some cases, but in very few cases, they reported like a discomfort or a fear of pain to undergo the transvaginal assessment. But there are also maternal characteristics that are linked with the declination of a transvaginal assessment. So, for example, some studies reported on high BMI patients or nulliparous patients that are not really expecting what they will have. And also, for example, smokers. And so all these categories, for example, are the same categories of individuals that have higher risk for preterm birth. So we should try to work on the counseling for the transvaginal assessment in order to achieve a higher acceptance rate for this procedure. I think this is very important. So this is a point we can raise until we reach a universal agreement on the universal transvaginal cervical length.
Yeah, great point. And I'll move to Gabriele next, but I want to make a comment on what you say. When we started in 2012, so we started right after Israel. Israel is always first, but we came soon after. At Jefferson, we had 75% acceptance, is now 75. The ones that don't accept for us here, if they don't speak English and you don't explain it well in, Chinese or Spanish or Hebrew or whatever. Actually, people have 3-4 term deliveries before. Many times they say, this is for preterm birth. I never deliver preterm. They may decline, but they still have a risk. So we counsel them. And now that we have, the sonographers are more, educated. For example, we still have a male sonographer who has the lowest acceptance rate. And I think once we have a chaperone, which obviously we have all the time, and more women accept. And it's interesting that in the US, obviously we have a very non-public system. In Israel, in Italy, and I guess in London, you have public guidelines that you can follow everywhere. Gabriele, in Italy, are there national guidelines on universal cervical length screening that you follow or you don't?
Italian guidelines are similar to AJOG because our guideline, both the ultrasound national guideline and the guideline of the Italian Society of OBGYN, recommend transvaginal ultrasound cervical length only in women with prior preterm birth. But for example, in my institution, we perform universal screening in both singleton and in twins. And I want just to comment regarding, the acceptance rate, because, for example, in our patient, in our clinic, we say that this screening can improve preterm birth, that can reduce the rate of preterm birth. But we also say to the women that if we perform also the transvaginal approach, we can also improve the anatomy scan accuracy, because, there is some scan that you can better see with transvaginal approach. For example, if the baby is cephalic, you can see the corpus callosum much better than with the transabdominal approach that is more challenging. And also, if it is breech, you can see better the spine, the kidney. So usually we use this approach also to complete the anatomy scan. So to assess the placenta, the location of the placenta. So I think, this approach that can make your anatomy scan much better, much complete. So, and once you use this approach for the anatomy scan, you just need a few seconds to take cervical length. So
yeah,
I think you can use this for the counseling of the women to increase the acceptance rate of the transvaginal approach.
Oh, that's a good idea. Yeah, no, I agree. I just want to point out something from both your study, Gabriele, and Ela's study, that screening seemed to decrease preterm birth more with earlier preterm birth. I think that, Gabriele, your relative risks were more impressive at less than 28, less than 24 weeks. And Elena, when you looked at less than 32, less than 34 weeks, you also found, your percentages of decrease were a little bit higher, which is encouraging. Obviously, it's nice to decrease the incidence of a 36 weeks delivery, but it's a lot better even to decrease the incidence of a 26, 30-week delivery. I hadn't noticed before those trends in both studies. Any comments from anyone on that?
Yeah, it is an important point. Maybe it's related to the therapy. I don't know, maybe it's related also to to the cerclage therapy, because some of them also received the cerclage. I don't know if Ella has any idea regarding, to speculate on this, and can be, a chance of finding.
Yeah, so for example, I guess that, for example, in Italy, we tend to offer progesterone until 36 weeks. So we miss that week. Probably this is something that might reduce the significant results between 34 and 37 weeks, because we don't have actually 1 week of treatment with progesterone. So I think this is a point. I agree with Gabriele about the preventive strategy that we use. But if we look at if we look at my subgroup analysis in singletons, asymptomatic singletons without a previous PTB, we actually had a significant result, even if with a lower risk reduction at less than 37 weeks. So probably something that further randomized control trials might explain a bit better. And I think that the methodology here is key. So I think and I hope that future studies will explain a bit more about this kind of trend and progressive trend for different gestational ages.
Great.
Can I just raise one question, Dr. Bragella? Because, in our institution, we have a high rate of women with uterine anomalies because we have a good center for hysteroscopy which treat these women. So we daily deal with the risk of preterm birth and counseling in these women. Because, cervical length is a very good predictor of cervical length in some subset of women, but have also a quite high, false negative rate, because there is also different etiology of preterm birth, of course. Do you think that we need to study cervical length in different subset of population, for example, also uterine anomaly, or other subset of population in which preterm birth cannot be related maybe to shortening of cervix? And also there is a lot of women with the cervical insufficiency where, there is with the trimester dilatation without any shortening in the prior weeks. Or you can think that, we cannot study so much rare subset of population, so we need to include all of them, just one umbrella population to treat and to screen.
Yes, excellent questions. And then I'll ask Ron and Doron for their last comments as well. Nice discussion. So, 20 some years ago, we published papers in all of these subpopulations, Mullerian anomalies, prior DNCs, prior surgical condensation, etc. And cervical length is predictive in everyone. So I think we don't have to study that again. I don't think we know very much if progesterone or cerclage are better in one population or the other. So I think we should study that more, even if a lot of our studies, and we've done together, most of the studies have included those women. So, for example, right now, if there's somebody with a bicornuate uterus, we would do cervical length screening and offer her progesterone and randomize it to cerclage or not to. So we would follow her the same way as somebody else. I don't know, maybe I'll ask Ron for any last comments he has as we finish the hour. Do you want to make any last comments, Ron, from Tel Aviv? You're muted. Let me unmute. I can unmute you. You're okay. You're good.
Again, I would like to come again to the discussion about transvaginal versus transabdominal. The benefits of transvaginal are immense, and it has the opportunity also to get overview of the fetal anomaly, some parts, and the vasa previa. But transabdominal, if you get a good image quality, it is reliable, and the correlation between the two measurements are quite good, and we should not feel that we are compromising ourselves if we offer transabdominal and get a good result. get a good imaging result. And this is my take-home message, because at least in Israel there are many subtypes of population who are embarrassed and don't feel the importance of doing a transvaginal scan when there is no indication, and why should it be done, and so on. So we have another tool. It is reliable, in good hand, and a good technique, and we shouldn't feel inferiority. This is my take home.
Thank you, and thank you for being with us. Doron, any last comments?
Maybe I want to ask Gabrielle and maybe the others regarding Gabrielle's question. In certain subpopulation, let's take women with some kind of malformation uterus, and they have additionally short cervical length. Would the treatment be different? I mean, if you take two women, one with cervical length of 20 millimeters and another with unicornuate, bicornuate, whatever uterus, and short cervical length, would you suggest different treatment? Because I know we do. I mean, we take women with malformation as a high-risk pregnancies, high-risk women, and we might offer cerclage for them, while for regular women without any kind of malformation, we wouldn't. So this is one difference that might be related to these approaches.
Gabriele?
So in our clinical practice so far, we did not have a different approach for these women. That's why I was asking for your approach in your country. So in my clinic, we do the same for so vaginal progesterone, cerclage, despite of the if the women has, for example, uterine malformation. Of course, if the procedure is feasible, of course, if there is an anomaly of the cervix and we cannot do the procedure, we will not perform it.
All right.
Cervix, for example.
So we've been together for about an hour. We always try to finish on time. I just want to remind everyone that AJOG internationally and SMFM now, as of 6 days ago, recommend transvaginal. So I know some people do transabdominal, but I just want to remind people what the international and the US guidelines say. And we have plenty of research and more papers to do. I thank everybody who is listening. I think we have a record number, if I can tell. We've had 2,000 in the past. I think we have thousands again listening today from around the world. So again, let me thank Elena, Doron, Ron, and Gabriele, and all of you listening. And thank you for being in another edition of AJOG MFM Live. Have a great day, everyone, and the speakers can stay on. Bye-bye, everyone.